Welcome viewers to Morning Grounds, Morning Rounds, Stony Brook Medicine's video series designed to bring together leaders, faculty, and staff for candid conversations about key initiatives and innovative work across our health system. Today, I'm honored to welcome Dr. Michelle Ballan, Professor of Social Welfare and Family, Population, and Preventive Medicine, and Director of the Leadership Education and Neurodevelopmental and Related Disabilities Center at Stony Brook University, and the recipient of the 2024 Department of Justice Crime Victim Service Award. Dr. Ballan is a nationally recognized leader in advancing care for individuals with intellectual and developmental disabilities and the founder of the Leadership Education in Neurodevelopmental and Related Disabilities, or LEND, Center. Through our discussion today, we'll learn more about how LEND has revolutionized interdisciplinary training for healthcare professionals, explored Dr. Ballan's pioneering curriculum development centered on individuals with disabilities as collaborators, and her work addressing intimate partner violence within this community. So, grab your coffee, settle in, and let's get started. Thank you so much for joining me today.
Thank you for having me. It's such a privilege.
Glad you're here. First, I want to say congratulations on your award from the U.S. Department of Justice, the Building Knowledge Through Research Award. I understand that there's only 8 people that were honored, 8 people in organizations that were honored. Tell me a little bit about what this award means and how it relates to some of the things that you've been doing.
Sure. Thank you so much. This award was really one of the highlights of my career. Receiving it from Christina Rose, who's the director of the Office for Victims of Crimes, and from the Attorney General, or the former Attorney General, Merrick Garland, really highlighted and brought to the forefront the importance of research for individuals with intimate partner violence and disabilities. The research was funded by the Lorena Arbus Foundation, the Nielsen Foundation, the National Institute in Disability, Independent Living, and Rehabilitation Research, and the Center for Victims Research. So really to have this cadre of funders supporting interdisciplinary research with people with disabilities at the forefront was so meaningful. People with disabilities are the victims of crime at astronomical rates when it comes to intimate partner violence. And when you put under the umbrella abusers that include personal care attendants, medical providers, and family members, in addition to the traditional individuals you think of as abusers, people with disabilities are the largest population affected by intimate partner violence. So the serious victimization that they experience is so troubling on so many respects, especially since they're left out of many national research surveys. But when you think about this award, it really brought to the immediacy the importance of not excluding people with disabilities, and how do we make every aspect and way for them to be included in the research. And so the work that I do centers people with disabilities as my colleagues, as my team members, as the experts, and survivors with disabilities helped with each grant. They help with assessments, and they help with the research that's conducted to interpret the findings.
That's really wonderful. What do you think some of the reasons why people with disabilities had been previously left out of the kind of data you cite on intimate partner violence?
Sure. I think some of it's due to the very heterogeneous group of individuals that make up what we call individuals with disabilities. So different surveys use different activity limitation protocols, use the Washington set. They use all different ways to measure who constitutes the individual with disabilities. And so we don't have uniform definitions across national data sets. And some national data sets only started including any definitions of people with disabilities only recently.
Well, I'm glad that they have, because it's clearly important based on the work that you've done.
Yes.
Tell us a little bit more about the LEND Center and how the interdisciplinary model that you use in the LEND Center can really inform what we're doing to better care for individuals with a variety of different neurodevelopmental disabilities.
Sure. LEND is It makes me smile just to even think about it. We were awarded the center in 2021 by HRSA, and we joined a national network of 60 centers. And it's a long time overdue because Stony Brook was ripe for really working in an interdisciplinary fashion. Now, in the last 3 years, we've been so fortunate. We've trained 1,500 healthcare professionals and students, self-advocates, and family members. HRSA dictates the healthcare professions that can be included as the focus of our training. But we take it a step further, and we involve, just like the rest of Stony Brook University does and Stony Brook Medicine, we bring in our colleagues across the campus with a unique series called Coffee with Experts in Novel Disciplines. So in addition to the other training protocols that make up the Lens Center training uniformly, we have individuals who come in and talk about archaeology, paleontology, economics, dance, art. And the reason we do that is because healthcare professionals need to account for the knowledge gained in those other areas. So for example, we had a fashion designer talk to us, and she did a line for individuals with neurodevelopmental disabilities. Our healthcare professionals learned from her presentation that we should be adding assessment questions for our patients around what does it look like around clothing choices. Does the individual wear the same clothing all the time? Sometimes we assume that it's preferential based on certain disabilities. But what we learned as a group is how important it is to take into account the sensory issues from a fashion design perspective. And we have other opportunities for training. We have didactics that address each of the healthcare professional disciplines. Self-advocacy and family leadership are also included there. And the second half of the year looks at how do we look at the individual with neurodevelopmental disabilities across the lifespan. When we start with a professional understanding of each different discipline's professional code of ethics, the training, the challenges in working with people with neurodevelopmental disabilities, and educate the trainees around what's needed to understand the different disciplines, it's much easier to learn how to respect other professions and to work in that interdisciplinary professional manner. We also do clinical seminars. You know, we're so fortunate to have the Early Childhood Clinic in Psychiatry and Pediatrics here, and they do a series of clinical seminars for us. We have the Alan Alda Center that does an incredible training for us, specifically for LEN trainees to learn how to have challenging conversations around communicating science around neurodevelopmental disabilities across different groups of stakeholders. We have a Disability Leadership Institute as a component. And we have other opportunities which include research and a research exposition and so many other components that allow for leadership, advocacy, clinical skills, and policy to really be developed across all of the disciplines together. And the training's free. So it's really opportunistic for people at Stony Brook and across the Nassau and Suffolk County areas to apply, and we've had hundreds of applications. In fact, for our long-term trainees, which do over 300 hours, we actually pay a stipend for people to participate.
I did not know that. That's great. You know, you talk a little bit about the interdisciplinary nature of it and how important it is, which I agree with. I think we don't have enough opportunities to really engage in interprofessional education. So we started our Center for Interprofessional Innovation. Tell me a little bit about what the feedback has been amongst the different trainees, whether they're students or practitioners. How have they received that, and how, you know, what have they said to you about the kind of interprofessional education and what it's like to see things through a different lens than they're used to?
Sure, they absolutely love it. They have no idea really what each profession's responsibilities are, but how they can also inform the professional roles that they have undertaken in this interdisciplinary manner. So let me give you an example, if I can. One of the components for the LEN program is an out-of-discipline rotation. So we bring in the trainees who cannot be from that discipline. So I'll use mine as an example in social work. We have social workers throughout the day who do early intervention, who are part of BOCES, who are in disability services in higher ed, who do clinical counseling at Stony Brook Medicine, who do professional, independent clinical care, and then who place people, let's say, in employment and living opportunities. When we have psychiatrists who sit through that, they realize, wow, I had no idea the school social worker was so involved in a student with disabilities' life. And so they recognize that when they change medication, they should not only consult the teacher and the family, but they need to call the school social worker. When we have dentists sit in that out-of-discipline rotation, they think, I had no idea of the role of social workers. If we involve them to the extent, maybe we can reduce anxiety in terms of preparing for patient visits. So we've seen how they change the way that they interact and that they call upon other professionals to help really focus on the way that they do work in terms of their consults with other people, their respect for other professionals. And of course, we're really fortunate. We have over 15 core faculty at Lend, and many of them come from Stony Brook. So we have Dean Stacy Jaffe-Gropak for physical therapy, Dale Coffin for occupational therapy, and so forth. Having individuals who are so dedicated to people with disabilities and to their professions and mentorship makes for an incredible opportunity for our trainees. And they've gone on to really secure numerous interviews for medical school in terms of residency. They've attained high-level positions. Our first year inaugural trainee in disability studies is now the director of the Viscardi Center. We have people who've really achieved incredible networking and leadership momentum in their careers. And I think it's most notable that our self-advocates have also gone on to really advance their leadership in terms of directing healthcare professions.
Well, it's a credit to you and all the other people who've worked hard to develop this center. So
Thank you so much.
Thank you. Tell us a little bit more about the scale of the dangers that people with disabilities face, particularly in relation to intimate partner violence, and why this is such a big public health problem.
Sure. So in terms of the public health crisis that's facing the country around intimate partner violence, it's important to think about what we were just referring to with how do we even measure intimate partner violence amongst people with disabilities? Because the statistics are really clear. For females, it's over $100,000 for the cost of intimate partner violence throughout their lifetime. For males, it's over $23,000, and there's over $2.1 trillion spent on medical care around intimate partner violence. But that doesn't account for people with disabilities fully. So if you think about the largest segment that's actually affected, the numbers are astronomical. They're probably close to double, I would imagine, if we're really accounting for individuals with disabilities, because they face serious victimization and violent victimization. They're more likely, women with disabilities, to be raped, to be stalked, to have physical aggression, to be victims of reproductive coercion. For women and men with disabilities, they're more likely to be subjected to physical violence. Women are more likely to be kicked, pushed, bitten. And when we really think about the scope of these dangers, it's not because they're vulnerable. And I'm really happy, Dr. Wertheim, that you didn't use the terminology of vulnerability, because people with disabilities aren't vulnerable to intimate partner violence. They're victimized by abusers who perceive them as vulnerable. The vulnerabilities lie in the way that we categorize barriers for people with disabilities. So there are social, economic, physical, attitudinal barriers that really delimit opportunities for people with disabilities to report abuse, to escape abuse, to go to shelters, to really get the necessary treatments that they need for the long-term medical and mental health implications that come along with intimate partner violence.
what are the things that you teach our students, or what are the ways that we at Stony Brook Medicine can do a better job of recognizing those signs where we should be looking for evidence of violence against people with disabilities?
So, because Stony Brook Medicine, yourself, and our administration has already been supportive, we've done a great job. We're one of the only schools of medicine that I know of in the country where we have a lecture on intimate partner violence and disability specifically. And in this lecture, what we do for our medical students is we discuss many of the things that you and I have been sharing here, which is who are the victims of intimate partner violence when they have disabilities? Who are the perpetrators? What are the signs and symptoms of intimate partner violence that healthcare professionals miss or overlook for different reasons? Everything from diagnostic overshadowing, to cultural bias, especially for men with disabilities, right? We have a lot of gendered norms, we have disability norms, and we don't realize how often men with disabilities are abused. And one of the research articles that I produced for the award that we were referring to previously, men were the focus. And of the 70 men who we looked at across disabilities, most were referred to the domestic violence shelter by criminal justice and legal services. However, over 60% of them had seen a medical professional.
That's a lot.
So we're failing in our ability to screen, assess, identify, and treat within hospitals, but not for our students in medical school, because what they're getting is the information around how do we assess, what questions should we ask, what are the different types of abuse. And one of the areas we really focus on that we find that medical students are really surprised by is what constitutes disability abuse. And because domestic violence reporting laws differ across states and what constitutes abuse in each state, by whom, we teach them about disability abuse. And what I mean by disability abuse is really utilizing the person's disability for exploitive purposes. This could be taking an SSDI check. This could be harming a service animal. This could be turning on and off an oxygen machine for somebody. It could be over-medicating or under-medicating them intentionally. If they rely on a caregiver, for example, to be fed, choking the individual while you're spoon-feeding more food than is necessary, causing them to aspirate, and different concerns as such. These areas that constitute disability abuse are often not even recognized or taught to others. So for our medical students to first learn this, and not just from me, but from survivors who have experienced abuse and come share this information with them, is very impactful. We also teach them to look for the unwitnessed signs of head, facial, neck trauma. If you're in a wheelchair, it's very easy for an abuser at that level to reach over and to choke individuals. So we're looking for signs like that they might not think of, based on working with non-disabled people as the majority of their population. However, with the numbers of individuals with disabilities who go to emergency rooms, who seek medical care, especially for physical violence, there's opportunities every day for our medical students to think about, should I ask the questions that I was taught in this class? And some of those are simple screening questions. I'll give you an example. In the last year, has somebody restricted the use of a cane, your walker, scooter, or another assistive mobility device? Just simply asking the question, right? But a lot of our medical students are afraid to ask the question because what happens when someone says yes? So in this lecture, we're also teaching them that simply showing empathy by saying, I'm very sorry that happened to you. This shouldn't happen to anyone, and you deserve respect. Let's try to keep you safe. Just giving them the words to move the conversation along is so important. And what happens when they say no? But I think one of the main components in medical school lectures around this should be really teaching medical students to think about Do they know the hospital rules and regulations? Do they know state laws? Have they gone out to the community and looked at a domestic violence shelter? Are they accessible for people with disabilities? Because there are very few nationwide, and they need to have the resources to help individuals.
These are such powerful questions, and the fact that you're giving people the right tools to be able to think about how to address them, I think is so important. And we're so fortunate that you've done this for all the people here at Stony Brook Medicine and helped countless of the patients that we see in ways that we might not otherwise have had the opportunity.
Thank you so much.
Tell me what it means to you personally to be such a pioneer in this work, and how do you envision its long-term impact on healthcare education, on the practice of medicine writ large, and of course on the people that we take care of?
So I don't think I'm pioneering in this respect.
Probably every pioneer says that.
I don't know. I think I'm fortunate. I think I'm exceptionally fortunate to have had the support of this university and the administrators and so many faculty and students to allow me to do the work. But really, it's for me around lending privilege to people with disabilities, to give them a voice to share their knowledge and to break down the barriers in healthcare with lessons learned from what they've experienced, both positively and negatively. And they've really stepped up to help. I mean, in terms of transition to medical and dental school, we have a spot now as one of the first introductions for our new medical students. And there's a patient panel of 7 to 9 people with disabilities who accompany me. We teach them how to move from the medical model of disability to the social model, how not to confuse disease with disability. But people don't want to hear from me. It's the panel that really shines light on how they can create a culture of empathy and sensitivity and inclusivity as they travel on their journey towards becoming physicians. And, I'm so grateful to the individuals who allow me to give them a voice, because they see me as an ally and their families do as well. But when you ask me, what do I envision healthcare education to look like? A few things. I think a leadership education and neurodevelopmental disability center should no longer be run by a non-disabled person. So my hope is within the next few years that I could step down to the assistant director position and elevate somebody who is a self-advocate who's come through our program to take over and really guide the future generation of healthcare professionals from the most disability-affirming lens that can be offered. I think having more students hear our lectures and come up to individuals with disabilities on my team and myself after and say, I have a disability, I didn't even know we can talk about it in medical school, that we're really cultivating the next generation of medical professionals who have disabilities, who are going to be role models for their patients. And if we could just do those two things, then I think I can retire.
I don't think we want to let you retire. But thank you so much for joining us today. It was a pleasure to have you with us. That wraps up today's episode. And thank you so much for sharing more about your advocacy work for individuals with intellectual and developmental disabilities. That truly is transforming healthcare education. Thank you to everyone at Stony Brook Medicine for all that you do to make a difference every day. So until next time, keep the coffee brewing and the innovation flowing at Stony Brook Medicine.